let's get into it. I got just a handful of things I want to leave you with today, and I've got them here on my summary slide. First one. First, when the brain is concussed, I didn't do it. Okay. Yeah, I lost the screen here. Oh, here it is. Okay. I'm not going to touch anything, I promise. Can I do it from here? That's the other slot, the other talk. There it is. There we go. I think that's it. Okay. So when the brain is concussed, the inner ear is concussed. Almost, I would tell you, virtually 100% of the time. It's just a question of how bad is the damage. And in general, the more severe the head injury, the more likely they've got an inner ear problem. The other thing that's in favor for folks with inner ear problems when they've got a head injury is a lot of it does get better on its own. Frankly, most of it does. And I think that's one of the reasons why it often gets undiagnosed. Second, these injuries are well described in the literature, and their existence is not controversial, not even remotely. Okay, so we're not talking about anything new here. Now, you can debate about an individual patient, but the presence of these problems are well established. Third, inner ear damage can be objectively measured and quantified. It's gotten especially better in the last 15 years, our ability to quantify these problems, especially compared to in the past where it was just kind of a guess. Objective identification requires appropriate testing. And this is where you're going to run into problems with the local doctors because reimbursement from insurance companies for any of the vestibular testing is so bad that nobody wants to do it. And in fact, I've been doing this for nearly 30 years, and there's less vestibular testing for these folks now than there was 30 years ago. That's how bad it is. I'm in an orphan specialty, too. There's not many of us around, so it's not like we make a lot of noise. Inner ear damage is treatable. It's not, a lot of people think, oh, you got inner ear problems, there's nothing you can do, but there's a lot of stuff you can do for it. And lastly, it is frequently missed or misdiagnosed. Okay, so we're gonna, first, this is the list of the ICD-10 criteria looking at the symptoms for concussion. And I will have you note that dizziness is the second most common symptom. And they have it listed as about 80% of TBI patients have dizziness. As I said, I suspect probably even higher, but many of it just goes away on its own. I know you guys are familiar with the pathophysiology of concussion. You've got these compressive and tensile forces as the brain kind of sloshes around in the head, and you get these pressure waves. And from that, you get the axonal disruptions that can cause all these symptoms that you talk about with the neurologists and such. Well, from my standpoint, there's kind of two big things that I see that I interact with: central auditory dysfunction and central vestibular dysfunction. I'm not going to talk about those today, but that's something I do see on a regular basis. The classic patient with central auditory dysfunction is someone who's got normal peripheral hearing, but they have trouble understanding people. And what's happened is those axonal connections to the auditory cortex have gotten disrupted. And there are some concrete testing to identify these folks. Central vestibular dysfunction is very similar. You've got someone with the vestibular or balance input going to the brain, and those axons have gotten disrupted. Those are the ones that the neurologists are mostly going to point out to you, saying, look, his eye movements are abnormal. When we do OPK or saccade testing, they're abnormal. Those are those folks. Again, I'm not going to talk about those today, but those we see a lot of. Okay, so when the brain is concussed, the inner ear is concussed, and this is not controversial. and I'm going to share with you a couple of studies here. The first is the first report of an inner ear concussion in 1871. Okay, so this is not new information. This is a Prussian soldier who suffered a glancing blow of a gunshot wound to his left mastoid. He had hearing loss from it and then later died. Dr. Samuel Moose did an autopsy on him, cut up his inner ear, and found that there was hemorrhage into his inner ear. And so that was the prevailing theory, that when someone gets a concussion, they've got an inner ear damage, it's from hemorrhage in the inner ear. Well, since then, we've actually found that that's probably not it can cause problems, but that's not the primary way they have trouble with their inner ear. The primary theory is this traveling pressure wave through the inner ear. The inner ear is filled with fluid, and it's connected to the cerebrospinal fluid. So when you get this big wave of pressure in a concussion, it gets transmitted to the ear and can cause damage to all the delicate membranes in the inner ear. There's also, again, kind of going along with what you heard about what happens in the brain, the damage is not just at the injury. You get some progressive damage down the road, and that's where we talk about the chronic phase there. Getting closer back to modern times, we've had some studies recently look at temporal bone histology and what does the inner ear look like in patients who've had concussions but not fractures through their inner ear. And there's a variety of pathologies you can see. You can see the actual inner ear neurons going to the sensory cells have been disrupted in moderate to severe degrees. Hair cell loss, which are the sensory cells, are lost in several cases. And there's also this unusual thing we call hydrops. Okay, when you're looking at the inner ear, there's sort of two components of fluid, endolymph and perilymph, and they're separated by this thin membrane. And when you get hydrops, you get distortion of the membrane, and you can see all kinds of distortion of function from it. And it's a common thing to see after head injury. It's also something we see with patients with Meniere's disease. So if you would, head injuries can cause a post-traumatic Meniere's type syndrome. Do y'all know what Meniere's disease is? Sorry about that. I talk about it so much. Meniere's disease is this awful problem where you have fluctuating hearing loss in the ear, ringing in the ear that comes and goes, pressure in the ear, and they get these horrible episodes of vertigo that last for hours at a time. And that's the syndrome, and this is one of the causes for it. So next I'm going to talk about a study from 1951, This is Hal Schuchnick, who was at Harvard. And this is a study that probably won't be repeated, and you'll soon learn why. But what he did was he took cats, and he taught them to do hearing tests. Don't ask me how he did it. I don't know, and I don't want to know. But he taught them how to do hearing tests. So he did hearing tests on a bunch of cats. Then he took a metal bar, and he whacked them on the head. Afterwards, he brought them back, and he did some more hearing tests. And then over the following several weeks, he sacrificed them and did some histology and looked to see what's going on in their inner ears. Now, keep in mind, he just looked at the hearing portion, did not look at the balance portion, okay? But the hearing and the balance portion of the inner ear are connected, and typically when one that gets damaged, the other does as well. So what did he find? First of all, most of the cats had hearing loss after blows to their head. And that happened in spite of no skull fractures. So it was strictly a concussive blow. Some of them had some improvement in the hearing in the following several weeks. The hearing loss that they found was they saw a bunch of different types of hearing loss, but there was a subgroup that was very similar to what you'd see with noise-induced hearing loss or acoustic trauma. The histologic abnormalities they saw after the sacrifice got progressively worse over time as well. And this all supported that traveling wave or pressure theory that we talked about before. And this is one of the big landmark studies for concussion in the inner ear. Looking at the balance portion of the inner ear, the vestibular portion, again, another study came out looking at temporal bone histology. And basically, it parallels what we saw with the cochlear or hearing portion. You're seeing loss of the neurons, loss of the hair cells. You're seeing vestibular hydrops, that kind of Meniere's type thing. You're seeing blockage of the lymphatic duct. The other thing that they saw, which was probably underrepresented in these studies, is loose otoconia. Okay, otoconia are calcium carbonate crystals that come from the gravity sensors of the inner ear, and they were knocked loose. And the significance of that is the source for the most common cause of vertigo and dizziness we see, which is benign positional vertigo. I'm sure a lot of people have heard the loose crystals in the ear kind of thing. This is one of the ways it happens. If you look at studies that actually tested patients with concussions who were dizzy, and most of these studies are at least 6 months out and they're still dizzy, the vast majority of them show vestibular or inner ear abnormalities. The unfortunate thing is so few people actually get tested for this. And the interesting thing is, even in these studies, the tests that were employed only tested small portions of the inner ear. They didn't test every aspect of it. To give you an idea, you have 5 different balance sensors on each side. Mainly only one of them was tested. So you got 4 others that are like, well, what's happening? We don't know. And it's certainly possible to have other abnormalities. In particular, the gravity sensors, which we call the otolithic organs, those are the ones most vulnerable to damage with head injuries, and they weren't tested at all in any of these studies. Okay, inner ear damage can be objectively measured and quantified. And when like Mr. Abraham sent his patient to me from my office, we spent a day and a half doing all kinds of extensive testing, looking at function, doing some provocative tests and things like this. And so it's all based off of the reflexes from the inner ear. And I'm going to go through the reflexes just kind of on a basic level to give you guys an idea what we're dealing with here. There's 4 main reflexes, and one other part of it I'm going to go through with you, and we'll go through these kind of quick. The first is the vestibular-colic reflex. Okay, so if you've ever seen a dog or a cat that it's lost balance function in their inner ear, their neck will be turned over like this. It's called the head tilt reaction. It's because of that stimulation to those neck muscles in the back of the skull, it pulls the head over, okay? Now, people don't do that. They might get a little bit of a tilt, but the main manifestation you're going to see with folks is they're going to talk about pain and discomfort where those neck muscles attach to the back of the skull. Next is the vestibulospinal reflex. You've got reflexes to all of your postural muscles. And when they're getting abnormally stimulated, the main symptom the patient's going to feel like, they're going to feel like they're tilting to one side or the other. They're going to feel off balance. It's kind of a vague thing. And I'm going to show you, again, if you see a dog or a cat that's lost function on one side, they will walk around in circles. As a matter of fact, a good couple that's friends of mine, they're both veterinarians, and they say, oh, that inner ear stuff, we diagnosed that over the phone. I'm like, what? How do you do that? Mrs. Jones, Miss Jones calls her dog's acting funny. And he said, what's he doing? He said, oh, he's going around in circles. He's got an inner ear problem. That's how they diagnose it. Anyway, so this is a lady who worked for me a while back, and she had a left inner ear injury that was really pretty much kind of subacute. But this is what she would look like if she walked in place and kept her eyes closed. Let's see, how do I do this? Oh. How do I get the video to run? Oh, here we go. So she's got a blindfold on.
Keep your knees high. Keep walking.
Oh boy, I forgot I moderated this. And what you'll see is she's going to slowly rotate to the left side. And we do this for about 30 seconds. This is kind of part of our routine physical exam. This is not one of the quote unquote tests per se. And she thinks she's walking straight. but she's rotating all the way over to the left
Doing
side.
good.
So if she was in a snowstorm, she'd go around in circles. Now, another abnormal, that's someone who's kind of got global loss of function on the left side. Now, if you're having abnormal stimulation of your your gravity sensor, you walk like this particular lady. And she is, how do I get this to run? Here we go. Imagine she's on a boat and the boat's kind of rocking back and forth because basically she just doesn't know where gravity is.
Take your time.
Another telltale sign, they always want to touch something and give them a third point in
turn around
space to
there.
let them
That's
know
good.
where they are.
And just come on back.
Thank you.
She'd been like that for 2
And
years by
today
the
is
time she got
November
to me.
20.
And she was mostly getting around in a wheelchair
Okay. Whoa.
because she
All
had
right.
so many
There we go.
falls
That's good.
as a result. And just to let you know,
And if you can walk, we'll be about 6 weeks of medical therapy.
this is after she was treated 6 weeks later, and she's doing great. Yeah, I know. She was one happy lady. I mean, you can imagine after 2 years of dealing with that, she's a pretty happy person.
Close your eyes.
We'll get into that in a little bit, but
I can't do that.
it actually was pretty simple in her case.
Awesome.
All right, so the next reflex is the vestibular ocular reflex. That's a reflex from your inner ears to the muscles that control eye movements. Whole purpose for that is when you're moving your head, you can coordinate your eye movements with your head movements. If you didn't have that reflex, every time you'd move your head, the world would be a blur. You'd have to hold your head completely still to get sharp, clear vision. If it gets abnormally stimulated, you can get some jerking movements of the eyes. Oops, wrong way. All right, so how do we look at this? This is just, again, a simple test we do in the exam room. In order to see these fine movements, you have to put the reflex at rest, okay? You have to prevent them from visually fixating. Imagine if someone wants to do the knee-jerk reflex. I'm sure you've probably all done this to yourself. If you stiffen up your leg and you try and get that reflex, it's not going to happen. You got to have the leg relaxed. And it's the same thing with the eyes. So the way we do that is we put them in the dark. So we get these diver's goggles, and inside the diver's goggles, I've got a little video camera with an infrared light source. And so what you've got here is my daughter with some goggles on, and behind her is just a monitor showing her eye. And I've got one of these in every one of my exam rooms. And so this is a demonstration of what a normal horizontal vestibular ocular reflex is. So she's going to spin around in the chair there. Why am I having trouble with this? There we go. And watch her eye. And she just thinks she's looking straight ahead. See, it jerks fast in one direction and slow back in the other. And as soon as she stops, it stops. So that happens every time you turn your head. And we can measure how fast it moves, if it's moving appropriately, etc. You also have these reflexes in the vertical dimension as well. Every dimension, we've got a semicircular canal. There's also a static vestibulo-ocular reflex. When you just tilt your head over a little bit, the gravity sensor senses that your head is tilted over, and it rotates your eyes back and tilts one up and one down. That's what the gravity sensors do. And if you have an abnormality of the gravity sensor, you can get a little bit of a distraction of the vision, and these folks will talk about blurred vision because their visual axis is not set up quite right. A number of these folks will do well with prism lenses because it'll allow them to correct their vision. I don't know if you remember, Hillary Clinton a number of years back had a concussion and she showed up with some prism lenses, and that's what it was because she was having double vision. The last reflex is the vestibular autonomic reflex. Okay, so if you remember the autonomic system, specifically the sympathetic division, is that one that people talk about as the fight or flight system. It's actually got a third component. It's freeze, fight, or flight. So you hear about the deer in the headlights, that's boom, they freeze. That's one of the reactions you'll get from the sympathetic nervous system. So there's a direct reflex from your inner ear to the sympathetic division of your autonomic nervous system. Well, what are the symptoms from that? The first most common symptom is nausea, vomiting, diaphoresis, cold sweats, very common with vestibular stimulation. You can also get heart rate changes and blood pressure changes. Very often patients with vestibular crises or vertigo, they'll have high blood pressure, and often they get mistaken thinking, oh, they must be having a heart attack or something. Then you can also get fainting, like that deer in the headlights situation. And you can get, the adrenal glands can dump out adrenaline to where you can get severe anxiety and even frank panic attacks. As a matter of fact, if you look at the DSM-5 diagnostic criteria for panic attacks, you'll see you've got 13 different criteria. And it says you need 4 of these to happen within a 10-minute period to diagnose a panic attack. Well, guess what? 8 of these happen routinely with a vertigo spell. So, but also I will say, give the psychiatrist credit. At the bottom in the fine print, it says must not be due to direct physiologic effects of a substance, i.e. they're not mainlining cocaine, or a medical condition, such as vertigo. So I guess technically, if this happens in the face of a vertigo spell, it's not really a panic attack. Although that's not what the ER doctor will tell you. The last sort of reflex is not really a reflex, but kind of an override system. Okay, so when all these reflexes we were talking about happen at the brainstem level, we don't think about them. They're some of our most primitive reflexes. However, if you start getting abnormal stimulation of these reflexes, the brain recognizes that ain't right, and it has to override those reflexes. So when it overrides those reflexes, that's a certain amount of your cognitive capacity you can't use for other things. Because in the hierarchy of needs, staying upright and not falling is pretty high up there. So a lot of these folks will have trouble with short-term memory, ability to concentrate, ability to focus. Now, the good news is, and this has been shown in studies, the good news is when you fix this, you see that all reverse. And you see them regain those. It's almost sort of like you're downloading that and you're freeing up that part of the brain to go back to doing other things. Daniel Kahneman wrote a book, Thinking Slow, Thinking Fast. And he had an analogy in there, or a story in there that I thought applies really nicely here. So he asked, when you're driving to someone's house, and you've never been there before, and you're on the street, and you're getting close to where you need to go, what is the first thing you do? The first thing you do is turn off the radio. It's because that's one less cognitive input, and so you can focus on what you're doing. And it's kind of like these folks have a radio going on, they can't turn it off. And that's my job, to turn off the radio. All right, next, objective identification requires appropriate testing. And as I mentioned, that's something we're sorely missing in the medical society today. If you look at the inner ear, like I said, there's 5 sensors on each side. You've got the 3 semicircular canals. I've got to list them on the left here, the horizontal, the posterior, and the anterior canals, okay? And then you've got the 2 gravity sensors, the utricle and the saccule. And they can have different function depending on if you're still or you're moving your head slow or moving your head real fast, okay? And that's what the bottom axis is, okay? And we measure the speed in something we call hertz, which is a cycle per second. And so if I move my head here to here and back again in 1 second, that's 1 hertz, okay? So the red bar at the bottom shows you the most common head movement range. So from 0 to about maybe 3 or 4 hertz is when we're mostly moving our head. So the first big test we ever had for the inner ear was the caloric test. We put the hot and cold water in the ear, and it measures only the horizontal canal and only at 0.003 hertz, which is so freaking slow, nobody moves that slow. And I'll never forget when I was teaching at Tulane, the residents would say, oh, the calorics are normal, so the inner ears are fine. I'm like, well, you got so much of it you haven't tested. How can you say it's fine? You can't. Well, it turns out there's other areas we can measure. We can do rotary chair testing for this larger portion of the horizontal canal. We can do active head rotation testing for the horizontal canal and the two vertical canals. They have to be tested together, though. Then we can check the saccule, which is on a posturography machine. We can check something called V-hit, which is real high-speed movements for the canals, and we can check those individually. The disadvantage is it's a really high speed. The advantage is you can check each individual canal. And then you can also check the two gravity sensors, but again, at very high speeds, and then down at zero. But basically, and then one other, these little red dots are the spots where we can check the function. Most places you go won't even check any of them, if anything, maybe just the first. And there's a whole lot more. And so when they do caloric, say, oh, it's normal, the patient's normal, that's nonsense. I can show you a long list of patients with normal calorics that have all kinds of inner ear problems. Same thing can be said about the auditory system. Okay, so when you talk about hearing, the human ear is sensitive anywhere from 50 hertz to 20,000 hertz. Okay, so very low frequency to very high. Now, where do we test on a routine hearing test? 250 hertz to 8,000 hertz. So you've got parts on each end there that we're not testing. And so periodically we have patients come in, we do hearing tests. Oh, your hearing's normal. There's no problem with your ears. Well, we really can't say that because we're not testing these other frequencies. We recently obtained extended high frequency testing where we can test up to 20,000 hertz, but you're not going to find that very many places at all. There's a bunch of provocative tests we also do, and I'm not going to go through these in any detail, but there's 3 real common conditions that you want to check for in post-concussive or post-head injury dizziness. Benign positional vertigo, which is going to be the most common. Endolymphatic hydrops, or sort of like induced Meniere's disease. And the third is this thing called third mobile window syndrome, which is something near and dear to my heart. First, the Dix-Hallpike test, and this is something that has become pretty routine even in the ERs now. Back when I first started doing this, nobody knew what this was. Now it's like everybody and their grandmother knows how to do it. The one thing I will say is, doing this test, what you're doing is you're turning the head to the side and you're putting the posterior semicircular canal in the most provocative position and you're looking for nystagmus. Without the goggles, you're going to miss a lot of them. So just looking at the eyes, you're going to miss it. You're also not checking the other canals, the horizontal and anterior canal. What we do is something called the Epley Omniax. It was a machine developed by John Epley, the guy who developed the main treatment for this, who is a good friend of mine, and this is actually the first device after his to be manufactured. But what this allows me to do is I can put the patient in 360 degrees in any position while monitoring their eye movements. And it's very effective. I'll show you what it looks like. This is what the computer screen looks like. And if you look, right here is a montage where the semicircular canals are. Over here is where the patient's body is. And this is that infrared video examination of the eye on the bottom left there. And so we're going to do a left Hallpike test. And I want you to watch and see what the eye does when we put him in this position. So we're turning him to the left. And see the pink canal? That's the one that's going to go down. And so now the eye is going to be active here. So if you've got those crystals and they're sloshing around in there, now watch, there's going to be a delay of about 5 seconds, and then he's going to have a rather interesting up and torsional type nystagmus, and that's uncontrollable. And you can imagine if that's happening, you're sitting still, it seems like the world is going around and around and around. And it doesn't last very long. It's like 15, 20 seconds and it goes away. But you can also get this in the other canals and they'll give you a little bit different symptoms as well. I have a book coming out. I have to self-promote too. In a couple of weeks, I edited a book, Third Mobile Window Syndrome of the Inner Ear. I've got 30 chapters and about 70 authors from around the U.S. and from Europe. And the reason this is important for you guys is about 25 to 50% of patients with this problem, the onset is after head injury. And that's something that I have found that is not so well known by a number of my colleagues. I submitted a paper recently to one of the journals, and the comment from one of the reviewers, who's supposedly an expert in the field, says, boy, this is great if people get to know that head injury can provoke this. And I'm thinking to myself, dude, this is like 20-year-old news to me, but in any event, this condition, there's kind of some very characteristic symptoms. They'll get strain-induced vertigo and dizziness. Like if they blow their nose or strain to have a bowel movement, they'll get dizzy. Sound-induced vertigo and dizziness, we call that Tullio's phenomenon. They get autophony, where their voice sounds too loud in their ear. They'll get pulsatile tinnitus, they'll hear their heartbeat in their ear. And they also get something we call conductive hyperacusis. They'll hear internal noises too loud, like the classic is, Doc, I can hear my eyes move. A number of these folks get sent to the psychiatrist because they're like, that's crazy, get out of here. But it is one of the symptoms that you can see with this. Now, you don't have all these symptoms for the disorder, but that's kind of the classic ones. And we have ways of measuring these responses. And this is one of the tests we do called vestibular evoked myogenic potentials. It's a normal reflex. You put a loud sound in the ear and you measure a reflex in the neck muscles. And you should see it in a normal patient, but at really, really high, loud sounds, like over 105 decibels. This particular patient we're eliciting that reflex at 55 decibels. 55 decibels, a quiet room. I'm thinking to myself, where can this person go and not be stimulated? I mean, this is like ridiculous. And what you see, this is a similar patient doing the nasal valve salve. I'll show you what their eyes look like. So what I'm going to do is I'm going to tell them, okay, take 1, 2, 3, take a deep breath, hold your nose and blow. So basically he's blowing his nose. And this is what happens with blowing the nose. And what you're going to see is a vertical torsional nystagmus at some point. It takes a few seconds for it to kick in. And the symptom correlate, he's going to tell me, I feel like I'm spinning. See, it's kind of downbeat torsional. And again, you can imagine if he blows his nose, the world is going crazy for him. This is the Tullio's testing. We put sound in the ear and watch what it happens with I guess that one I got to press individually. All right, so this one, you're going to see the eye go up and to the left. And then when the sound stops, it comes down. And he'd probably feel more of it just that the world's tilting on him, if you would. And then this is a guy who can generate it internally by humming to himself.
Okay, all right, keep your eyes wide open. And do you want me to make the sound or you want to make the sound?
No, I have to do it.
Okay.
So I have to kind of practice.
So he's going to hum and produce the same thing. One of the first patients I ever saw this was an attorney who told me when he'd go get home, he'd go in the backyard to call for his dog, and he'd use this high-pitched scream, and it would just about knock him over. And I said, go ahead and do it for me.
Can you try to hold that pitch? Sure.
Anyway, so that's what the Tullio's phenomenon does. You get nystagmus induced by different sounds. And one of the first third mobile window problems we saw with this is lack of bone over the top of the superior semicircular canal. So this is called superior semicircular canal dehiscence. And what you're seeing over here, I guess it doesn't show up here. What you're seeing over here is that's the top of the superior canal. It should have white bone all the way over the top of it. So in this case, the brain is getting, any change in pressure in the brain is getting transmitted through that canal which is going to stimulate the balance sensors and cause vertigo and dizziness. The nice thing is there's a surgery to fix that. You put bone over it. This was actually an attorney as well who got a quintessential New Orleans type injury. He was on a Mardi Gras float, and a big tree branch came and hit him in the head. And that was the onset of his problems. It turns out there's a whole bunch of other defects we've found that can give us very similar symptoms. And this is a slide I borrowed from a friend of mine, a colleague from France, who's kind of cataloged them and given a whole classification system for these bony dehiscences. Bilaterality and combinations. One of the things that I would emphasize here is when someone gets hit in the head, it's more common than not for them to have injuries to both inner ears than just one. Because when you get hit in the head, the pressure goes everywhere. Chances are they might have a little bit worse problems on the side of the injury, but the whole head gets hit. So bilaterality is probably more common than unilaterality. The other thing is, it is very common to see both central and peripheral problems. So it's not a question of did he have a concussion or did he have an inner ear problem. He probably had both. That's not unusual. It's kind of like saying, oh, he had a broken hip, so he can't have a spine injury. Well, of course he can have both. We also check for malingering in these cases as well. It's kind of infused with all the different studies. One of the things that I'm still amazed that patients will come in and try and feign on a hearing test. You cannot fake a hearing test. We know where your hearing is, even without your cooperation. Similarly, with a lot of the balance stuff, you can't fake it without us knowing it. So it's one of these things that I always kind of mention to folks. Interestingly, back when we accepted all of the different insurances, we had a lot higher number of malingerers. After we got rid of all the insurance plans and went to straight cash, we saw a lot less of them. And I think it's because the attorneys weeded them out for us ahead of time because they weren't going to pay for somebody that they didn't believe in. So we don't see that. Now what I see, the main ones I see that are malingering are from defense attorneys. Inner ear damage is treatable, okay? So acutely after a head injury with someone who's got an inner ear problem, really pretty much the most common recommendation is just take it easy and give it a few weeks, just supportive care, because most of them will get better. Okay, similar to other concussive type symptoms, the inner ear symptoms, even the BPPV frequently will get better on its own. If they're still having problems at 3 weeks, that's when I think it's appropriate to treat the BPPV. It's appropriate to start them on vestibular rehab therapy, which are basically exercises to get the brain adjusted to the damage that's been done. If they're still having problems after going through that and it's beyond 3 months, then I think a full diagnostic workup is warranted in looking for why do they still have symptoms. Unfortunately, most of the patients I see, they're several years out before they get to me. So I almost never see them this early. Lastly, inner ear damage is frequently missed and misdiagnosed. And part of it is just who's got the training and expertise to deal with this, okay? If you look at neurology, neurologists are brain doctors. They're really not trained for the inner ear. There is a subgroup called otoneurologists that really kind of look at vertigo, dizziness. They know about the inner ear, but it's less than there's less than 100 of those in the country. As for ENT or otolaryngology, there's about 12,000 of us or so. Of those, there's less than 250 board-certified neurologists like myself. So we're talking about maybe 350,000 docs in the whole country that have training and expertise to deal with this kind of stuff. So we're not talking about huge numbers here. And in fact, there are significant financial disincentives for my colleagues to take care of these patients. For example, I spend an hour with a new patient who's dizzy. They're complicated. You have to get all the information down from them, and it takes time. The way the insurance system is set up, my colleagues will get paid the same for spending an hour with a dizzy patient as they will with spending 5 minutes digging wax out of somebody's ear. So it doesn't take long for them to figure out, heck, I'll see 10 patients with wax in the ear and screw the dizzy patient. So a lot of them won't even see dizzy patients at all. As a matter of fact, I had a good friend of mine who edited a textbook. He asked me to write a chapter for him, and the textbook was about dizziness, okay? And I was with him and two other colleagues, and we're having lunch at a meeting, and they start talking about how do they get out of seeing dizzy patients. And I'm thinking to myself, you just wrote a freaking textbook on it. You know, it's like, oh, you know, I limit them 1 day a month, I'll see them. That's it, you know. And it's because they don't want to see them, and it's because of the financial disincentives, the time they take, et cetera. The other thing is the equipment. The equipment is very expensive. You'll lose money on them from the insurance companies. And so you're seeing less and less testing done. And certainly from the standpoint of what you guys are looking, you want objective data on what's going on with these folks. The symptoms can be vague. A lot of these folks have a hard time describing the symptoms, especially if they've had a concussion. Heck, they're having a hard time finding words for door and cat, much less what's vertigo or dizziness. The symptoms can often be attributed to the brain or inappropriately attributed to the brain. I had one particular patient of mine that I just love. She was dizzy for 35 years before she got to me. And she went everywhere. I'm talking, you name a major medical center in the United States, she went there, and everywhere they told her, ma'am, you had a concussion, the part of your brain for balance has been damaged, and there's nothing to be done. She had to use either a wheelchair or a walker to get around. She finally came to see me. After about 6 weeks, she had no longer needing to use a walker or wheelchair. She's walking on her own, and that was about 10 years ago. And now she's starting to get arthritis because she's getting kind of old. But it was just one of these things where she got labeled a concussion patient, and then nobody ever looked at the ears. And then the last one, this is something that, I'll be honest with you, is something new to me, is something called vestibular agnosia. It's something the neurologists are much more familiar with. Agnosia is this inability to sense things. And apparently it's very common in concussion patients. And I saw a paper recently describing vestibular agnosia. And this is more in the moderate to severe TBI patients. And what will happen is they'll have vestibular problems, but they just don't recognize it. And I've certainly seen that with some folks. And they took a group and they did all the testing. It's like, wow, they got all these problems, and they don't even realize it. They just fall. So that's another potential hurdle for these folks. So that's pretty much my talk. And I could spend a week talking to you guys about inner ear stuff, but I know you don't want to spend a week with me. Do y'all have any questions? Yes, sir. Repeat yeah. So the question is, what about tinnitus? What's the cause for tinnitus in my patients? So I would break tinnitus up into sort of two categories. There's central and there's peripheral. Okay, so peripheral means something abnormal going in the inner ear, like the third mobile window patients where they're hearing their heartbeat in the ear. It's because of this abnormal stimulation, okay? Then central tinnitus is very similar to phantom limb syndrome. Okay, so you've heard where someone's had their leg amputated and they say they can still feel their toes. Okay, so obviously their toes aren't there, but the part of the brain that sensed their toes is still there. Okay, it's the same thing when you have hearing loss. Let's say you have severe hearing loss at 8,000 hertz. There's a part of the brain that senses 8,000 hertz and it's not getting stimulated, so you hear something. And that's what central tinnitus is. And that's probably the majority of tinnitus is central tinnitus from hearing loss. And there's a number of different treatments for it. I would tell you, it's one of the things I always tell patients, we can get a lot of things better, but your tinnitus is not going to get better. And I explain that's the reason for it. Now, there's things we can do to help you cope with the tinnitus. For example, using a hearing aid so you can get the external sounds and amplify things to where it kind of drowns out that central tinnitus is probably the most effective means. There's also some cognitive behavioral therapy that helps patients cope with it. There's some interesting things coming out with transcranial magnetic stimulation, where you can basically zap with magnets part of the brain that's causing the tinnitus. And surprise, surprise, it actually works, but it doesn't last and it comes back. But that's something I think is very interesting coming down the pike that may help folks. Any other questions? Yes, sir. I'm an otolaryngologist, ear, nose, and throat doctor who is subspecialized in neuro-otology and skull base surgery. Neuro-otology. Yes, sir. That's right. That's right. Yeah. So basically, he said he had an interesting case where he could do a PET scan and demonstrate the area of the brain that was causing the tinnitus, which makes sense. And that's how they're able to identify it for the transcranial magnetic stimulation. Actually, the forerunner to that was a colleague of mine was actually implanting electrodes in the temporal lobe, which is very invasive. And it worked. Again, it worked, but it worked about 6 months, and they had to kind of redo things. And so once they came up with the transcranial magnetic stimulation, that kind of fell away. Yes, sir. Oh, absolutely. My patient population literally is from around the globe. I have a guy I'm operating on next week from the United Arab Emirates. He's got a really interesting case with an isolated posterior canal vestibulopathy, which is really kind of bizarre. But no, absolutely. Oh, yeah. Yes, sir. I've done both. The question is, do I?
My client, he's still consulting with them after the initial evaluation. I'm sorry.
With Mr. Abrams, the patient he referred to me was originally just a, evaluation. And that was it. So I saw him, evaluated him, talked to Mr. Abraham on the phone, and he's like, well, is there anything you can do for him? I said, well, yeah, there's a lot of things we can do for him. He said, well, go ahead. So then I became a treating physician, and I've been treating him ever since, and he's responded quite well to treatment. Sure. Well, right. How do I collaborate long distance? First of all, most of the patients have had extensive vestibular rehab before they even get to me. And so if they need some afterwards, I typically will send them back to where they were originally. The one thing with the COVID pandemic was it kind of pushed us all into telemedicine. And so I find even patients that are around the block, I'm doing telemedicine visits for now. And so when I see folks, most of what I can do after the initial evaluation, I can pretty much handle with telehealth. The only other exception is if they have to come in for surgery. Certainly. Yes, sir. That's a good question. Is there an objective test for hyperacusis? And the answer is actually yes. But I would counter that with hyperacusis. Some people use that as a diagnosis. I think of it more as a symptom. Because when someone comes in, they tell me they have hyperacusis or they talk about sound hurting their ears. My question is why? And usually we can find a cause for why. But if you look at the conventional hearing test, okay, there's anything sound less than 25 decibels or sensation levels considered normal. So a lot of audiologists, once they get to 20, 25 decibels, they stop testing. My audiologist is very attuned to this hyperacusis symptom, and she will keep going and see how high can you detect sounds. And some of these folks can have such hypersensitive hearing that they can hear sounds at minus 10 decibels, which is it just boggles my mind that they can do that. But it's something that we've been doing for like the last 10 years, and it's pretty interesting. So I guess in that respect, yeah, we do have a test for it.
What about loudness, loudness, discomfort levels?
Sure. So typically when you're talking about loudness, discomfort levels, you're talking about the upper end of, okay, so we're talking about dynamic range. So when you're doing a hearing test, you start off at the very softest sounds and you keep going until, I can barely hear it. Okay, so that's your sensation level. And then you get louder, 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 louder. Oh, that's too loud. Okay, and that's your your level that's too loud. So that is your dynamic range. Okay, so the interesting thing is as you lose hearing and this comes down, this doesn't change. So you ever saw the old movies where there's this little old lady who's got bad hearing and people will talk to her and she'll say, well, speak up, Sonny. And they'll speak a little louder and say, no, speak up. And then finally they'll yell at her. And she says, well, you don't have to yell. And it's because by the time she hears them, it sounds like they're yelling because she's got a dynamic range like this. And so I think that's kind of what you're talking about. That can be a symptom of hyperacusis, if you would, too. It's one of these things that's kind of ill-defined. I'm thinking more on the upper end where they have these people with just really hyperacute hearing.
I didn't know if there's normative data, and I see some audiologists sort of saying, well, those people can tolerate up to about 95 to 100 decibels and not be uncomfortable. The threshold is lower than hyperacusis, but it might be really uncomfortable, say 65, 70 decibels.
Oh, and even lower. Yeah, no, I have a handful of patients that come in with noise-canceling headphones, and just, like 30, 40 decibels is bothersome to them.
We have normative data on health controls to say most people are in the range of comfort versus TBI.
That's the question is, do we have normative data, especially on TBI patients? I don't know. I'm not aware of any. But that's something I'm going to have to look into that because that's a great question.
Well, there's one thing we didn't know today on the practice.
Thank you. Thank you for that.